All right, this is Dr. Barron, one of the subject matter experts at EHI. Just before we get started, a couple of housekeeping items. We are on mute for everybody, but Dominic and myself. If you do have questions along the way, though, please feel free to put them in the chat box or in the questions box. So without further ado, what we'd like to discuss today is a little bit about the remote patient monitoring, the chronic care management program, and a bit about the telemedicine programs. And these are essentially ways that you can connect with your patients during the COVID-19 crisis, but again, hopefully beyond that as well. So I don't have to tell you that the COVID-19 crisis has presented a real challenge to physicians. Patients have been, by and large, asked to stay home because they are at risk for either transmitting or being the recipient, the heir, if you will, of a COVID-19 infection. So clinics are pretty slow these days, but there are multiple modalities that can allow patient care to continue remotely. Again, right now we'll talk about the RPM, Remote Patient Monitoring Program. We'll next talk about the CCM, the Chronic Care Management Program, and then we'll touch on telemedicine as well. So what is remote patient monitoring? In essence, this is a program that was developed by CMS in 2018. The idea being that you would send the patient home with a connected device, blood pressure cuff, glucometer, pulse ox, or scale, that allows a practitioner to be able to view data real time on an internet, a HIPAA-compliant internet portal. So the nice thing about this is that it allows patients to share with providers information about how they're doing, and for physicians and nurses to spot trends in data to catch abnormalities before they become emergencies and can result in an ER visit or in a hospitalization. So CMS, again, introduced this program in 2018. They love the fact that it can keep patients out of the hospital. They like the fact that it is a significantly cheaper endeavor than having a patient admitted. And because of that, actually, they've been very generous with their reimbursements. And we'll talk about that in just a moment. The nice thing is that the only criteria are that the patient needs either one or more chronic condition, that the patient has seen the patient within the past year. They don't recommend or specify the diagnoses that are required for this. Although, certainly as you get started, I'd recommend that the diagnosis makes sense for the device that is deployed. So, but there is some creativity and flexibility within that. So a scale, for example, might be utilized for a patient with obesity, taking weekly weights. It could, however, also be used for a patient with CHF or in renal failure, in whom keeping track of daily weights is pertinent. Similarly, there's no recommendation or specification about the frequency of data acquisition. That is how often patients actually obtain data points. There are some suggestions among the field that it would be good, obviously, to be on a regular pattern of data acquisition points. And also, it seems like the best bet, just to make sure, is to have 16 points in a month. What are the benefits for the patient? Well, of course, it allows the patient to remain at home to have their vitals checked or their physiologic parameters checked. It allows the practice to keep close monitoring of the patient's vitals to help improve compliance with the patient care plans. So we can get a feel for what the blood pressure is doing, for example, and if it's if it's the blood pressure medication the patient's on is actually tracking. We can prevent trips to the ER and hospitalization, and in these days, it is important for preventing iatrogenic infection. And finally, patients are able to stay at home longer than going off to a skilled nursing facility or the like. There is some evidence that a patient would do better with an RPM device with real-time monitoring as compared to intermittent monitoring for which the patient brings a list of their blood pressures or a list of their sugars into the hospital. So the AHA policy actually looked at the fact that RPM can actually reduce systolic and diastolic blood pressures significantly when compared to usual care and self-monitoring alone. So again, what that means is that the patient who is monitoring their blood pressure at home or their blood sugars at home, they actually will do better with real-time monitoring than with the intermittent information that's provided. Also, according to admittedly non-randomized trials, RPM does have the potential to improve outcomes in AFib, to enable accurate and early detection, decreasing mortality, and of course, hospitalizations. In this paper from JMRR Cardiology, they concluded that the number and cost of ER visits and hospitalizations was reduced for patients with COPD and with CHF when comparing data before or after the SMART program, what they term their RPM implementation. And again, that's compared to patients with intermittent measures at home. Well, what about the provider? Well, for one thing, the practitioner gains better information in order to care for patients, whether or not that patient's coming into the hospital. So it's a great way to augment, if you will, what you might be doing with telemedicine or phone calls when patients are hesitant to come into the clinic right now. Certainly, it avoids the spurious effect of having a patient come in and having their measurements taken. So it avoids problems like white coat hypertension. Again, it avoids emergency visits. So the nice thing about that is that the stream of patients is now into your office for, say, management of medications, as opposed to the hospital for an ER visit or a hospitalization. The final provider benefit, and this is huge these days, where a lot of practices are cash strapped because of the fact that right now patients are just not coming into clinic. It helps to increase revenue. So the first month, practitioners are reimbursed $140 per patient. Thereafter, $120 per patient per month. So there's 3 major CPT codes and 1 additional CPT code that are pertinent to billing RPM. The first is remote monitoring of the physiologic parameters 99453 for initial setup and patient education on the use of equipment. So again, the 99453 code pays about $20 and it's for setup and education on the equipment. 99454 code is for transmission of that data from the patient's home to the internet accessible portal, and that pays $69. Finally, the third of the major codes is 99457, which pays $53 for assessment of the data coming in and interactive communication with the patient. So that's for the first 20 minutes of the data analysis and interaction with the patient. But there can be an additional 20 minutes billed under the 99458 code, which pays an additional $43. So if you have a complex patient, you're looking at, for the first month, about $180, thereafter $140 per patient per month. While this is a CMS program, there are a number of commercial payers that are now paying for it, again, understanding the fact that they can avoid a costly ER visit or hospitalization. So to mention some, Aetna, Humana, United Healthcare Community, WellCare, Elder Plan, Clover, and Amerigroup. And that's just a short list. There's a more extensive list than that. So with that, I'm going to pass the baton to my colleague, our RPM guru, Dominic Greco. So let me stop sharing. And Dominic, I'll have you take over.
Thank you, Josh. So I'm just going to go through a quick overview of what the patient is going to be expected to do at home. So, what I have with me is a pulse oximeter, which the patient would be sent home with, along with any other connected devices that the patient may have, and show you how easy it is. So I'm just going to go ahead and start a reading here. So just like that, the patient just sent over a reading to the doctor, and this data is easily viewable in our EMR. So what I'm going to do is show you how the data is going to be coming in. So data coming in will come in on a real-time basis. So once the patient takes the reading will get sent in and will be easily viewable, sorted by the time it's coming in. That way you can make quick actions on any patients that you may have. And it's just a very simple process that the patient needs to do at home to send in these readings, and we get a much better view of the patient at home when they're at home. So that's just how data collection works, not really too complicated, and it's very easy for your patients to do at home. Josh, do you think I missed anything? Anything you want
Nope,
to add?
that sounds about right. So again, we're able to see all of the data points that are coming in. It's especially pertinent that that Dominic was showing a a pulse oximeter currently. And the reason for that, of course, is during the COVID-19 crisis, a great way to keep track of patients who've tested positive or for whom you're concerned is via pulse ox. And again, obviously that patient should be kept at home as much as possible. But when their pulse ox, when their SpO2 starts trending down, that's a perfect time to rethink that decision. So it's a great way to, again, keep track of your patients who might be ill with COVID-19. So I will mention that we are able to provide a number of services at EHI. We're able to provide the technology that connects, that is the software. We are able to provide the technology as well as our nurses, our LPNs, who are able to keep track of the data as it's coming in, as well as to make calls with the patient to fulfill that interactive communication. And finally, we're also able to provide provide devices to you. So if that's of interest to you, please feel free to shoot me an email, jbarron@ehier.com. I'm going to go on and switch tacks a little bit here, and we'll move over to chronic care management program. Again, if you have any questions, please feel free to put them into the question section or into the chat. All right, so chronic care management. So in this portion of the webinar, we'll review what the CCM program is, how it helps your practice, who benefits from the program, how we can help, and what are your options if you do want to initiate CCM program at your practice. So the chronic care program is a CMS initiative to bridge the gap in patient care. And essentially what this is a development of a chronic care plan that are pertinent to the patient's chronic conditions and monthly calls to the patient to ensure that the patient is following this chronic care plan, and also to ensure that there are no barriers to the patient's good health. We generally would place calls every month, reinforcing the care plan and essentially checking in on patients, though during this pandemic, we are checking in more frequently than that on, especially on patients for whom you're concerned. And so we're making weekly calls for them. The end goal is that patients are less likely to be admitted to the hospital with this early intervention and symptoms. So again, this is another way where we can keep patients home and healthy as opposed to going into the ER or being hospitalized. What are the qualifications to this program? Well, for one thing, the patient needs to have 2 or more chronic conditions that are expected to last at least 12 months or until the death of the patient. Those chronic conditions, again, are expected to place a patient at significant risk of death or acute compensation or decompensation or exacerbation or a functional decline. So some of these chronic conditions, for example, might include Alzheimer's disease, other dementias, arthritis, AFib, cancer, cardiovascular disease, depression, diabetes, hypertension, and any sort of chronic infectious diseases. The main billing code is 99490, and that's basically that pays $42 for 20 minutes of clinical staff time directed by a physician or other qualified healthcare professional per calendar month. Essentially, that assumes 15 minutes of work by the billing practitioner per month. So to be clear, this is time spent working on the care plan and communicating with the patient on those at least monthly calls. This is something that can be billed as incident to. Now, at the beginning of this year, CMS introduced two other billing codes. The G2058 code can be used twice for additional 20-minute increments. So what that means is that while a typical CCM call for about 20 minutes time spent can be billed exclusively with the 99490 code, paying $42, you can bill that G2058 code once for an additional 20 minutes for a total of 40 minutes and get paid $79, or for a total of 60 minutes and get paid $118. So for your more complex patients, you are in fact able to bill more based upon time. So how does your practice benefit? Of course, your patient compliance improves, and that's huge. Right now, we are looking at our MIPS measures, and our payment is related to that. Our CMS reimbursements are related to that. Starting next year, however, and this is pertinent to both RPM and the CCM programs, starting next year, we're entering a mode of value-based care where our outcomes are going to be linked, or that is, our patient outcomes are going to be linked to our reimbursements. So this is another way, this and RPM are another way to kind of keep track of patients, make sure they're doing well, and ensuring their optimal outcomes. Obviously, fewer hospital admissions, fewer ER visits, which again means that the patient, the patient is essentially coming into your office as opposed to going into the emergency room. You, of course, have improved communication with your patients. And finally, it improves the socioeconomic aspects of patient care. So we're able to identify barriers to care, including nutritional barriers to care. In some cases, we'll set the patient up with community programs, Meals on Wheels, for example, when possible or when pertinent, transportation to the appointment. So what do our CCM nurses do at EHI? We have a panel of LPNs that are responsible for helping to construct the chronic care plan and making these phone calls. They are essentially an extension of your practice's front office. So we reach out to the patients on behalf of the doctor. We can review, and then the doctor reviews the notes, allows billing to proceed. We have a very talented panel of LPNs, so many of them are multilingual, including Spanish, various Indian languages, Arabic, Persian. Our nurses, when they call, are typically reviewing medications. Is the patient taking the medication? Do they have any side effects? Do they require refills? Has the patient been hospitalized? What are the socioeconomic aspects of patient care and barriers to health? And of course, we have a panel of questions that are built out that target the symptoms of the patient's disease processes. So this is an example of what this would look like. And so you can see here, this is our technology. This has a series of questions. Again, this is just one page amongst it. It shows that the patient's on amoxicillin and aspirin, and so there's a number of questions regarding potential side effects. So conditions of excess stomach acid secretion from the aspirin, nausea, feeling like they throw up, heartburn, stomach cramps, reviews the last appointment, their current labs and lab orders, and any sort of disease symptoms. And you can see on the right here, we're starting to develop a note that would be sent to you at the culmination of the month. So when would the nurses need to communicate with practices? Of course, if a patient needs an appointment that's sooner than is required, so if the patient has concerns that warrant a visit, or if there's or if there's side effects from medications, the patient needs refills, the patient has had an ER or hospital admission, or the patient has been screened and resulted in an alarming result for, say, a depression screen or a fall risk screen. Just talking through some of the aspects of the comprehensive care plan. It'll include things like the problem list, the expected outcome and prognosis, treatment goals, symptom management, planned interventions and identification of the individuals responsible for each intervention, med management, community and social services ordered, description of the agencies that can be helpful, and of course, the revision of the care plan and schedule for periodic review. So we can help here in a couple of ways. One is we can provide the CCM application only at the cost of $10 per patient per month, or we can provide the app and the use of our care coordination nurses for $20 per patient per month. So again, if you have questions at all, my email is jbarron@ehihr.com, or you can contact me directly at 973-435-6501. We'll be on here for a few more minutes. I do want to show you a little bit about our telemedicine platform. And again, please, if you have any questions, do feel free to type those questions into the chat box. Now I see my colleague Yanni is on, so I'm going to show you guys what our telemedicine platform is, and I'm going to invite Yanni to the party here as a potential telemedicine patient here. So let me show you what our telemedicine platform looks like. Now I'm sure you know, again, at this point we are at a stage where we need to interact with our patients and do so in a remote manner. So we've talked about RPM, we've talked about CCM, but how do we actually see our patients at a time when it's increasingly difficult for patients to come in? So telemedicine is the perfect choice for that. In most states, there are what are called full parity laws. And what that means is that we are able to bill for telemedicine visits at the same rate as an in-office visit. Now, it used to be that Medicare was demanding that these visits can only be billed if you're operating from a rural health clinic. However, they've changed that with the current pandemic, such that we're able to bill Medicare for this. So this is our telemedicine platform here. And so right now I've shown myself as offline. I'm going to go ahead and put myself available as for telehealth sessions. Here I am. Here's a little capsule video of me. I'm able to see my patients that are scheduled, my no-show patients, my patients that are ready to join, my patients that have been seen through the telemedicine platform. And I'm just going to go ahead and invite a patient. So I will pull up a test patient. And I'm going to send Yanni an invite. So I've invited Yanni to the telehealth session. From here, I can connect when I'm ready. I can send the invite again if need be. And so I'll just wait for Yanni to show up. I think he's still on. One of the nice things about our platform right now is we have the ability, and I'll show you this in just a moment, to invite multiple persons to the telemedicine visit. So let's say I am seeing a patient, I've got a question, I can bring in a specialist to curbside them by sending them a text message or an email to invite them as a third party, or I can invite another family member to the telemedicine visit if I need further information from them. So I see that Yanni's ready to join. So I'm going to click on my Connect a Patient. And here I am down here as a physician. And in just a moment, we should be able to see Yanni coming in. While we're waiting, I do want to mention that if you are connected with our EHR, hey Yanni, if you're connected with our EHR, I am able to directly access the chart. And this is pertinent so that I'm able to review the details of the patient before I see him or her. I also have the ability to come in and write a brief SOAP note. This is how you would document your telemedicine visit. I can write an ERX from here. I can send an invite if I need to bring in other individuals as well. I also have a chat box, so I can send a message to my patient, and especially if you're troubleshooting, for example, Yanni, please turn on your microphone. And actually, I can hear Yanni okay, but oftentimes when you're dealing with an older population, sometimes it helps to have a way to communicate with them in another manner. Of course, I can see in my upper right-hand corner the timer. I can mute my mic. I can share my screen if there's lab result or radiological result that I want to share with the patient. And finally, I can take a screenshot. So this in a nutshell is our telemedicine platform. We do have it available now for $49 per provider per month, and that's for unlimited calls to your patient. When you consider the fact that telemedicine visits are now paying commensurate with in-office visits, essentially you just need to see one patient in order to pay for our platform. So again, I will stop there and see what questions people have. If you do need to get going, please feel free to reach out to me at jbarron@ehieh.com, and I'll pop that back up here, or to call me at 973-435-6501. So let's see. I don't see any questions coming up yet. Again, right now we're in a state where everyone is muted and we don't have the possibility of unmuting. So if you would please go ahead and type any questions that you might have into the chat box or into the question section. If there's no questions, I do want to thank you very much for your time today. Again, please feel free to reach out to me if you have questions, or if this is something that, if you'd like to pursue the remote patient monitoring, chronic care management, or telemedicine platforms with EHI. Again, thank you very much for your time. I will stay here for a couple more minutes in case any questions come up, but I do appreciate your time, and thank you. So Dr. Faruqi, I see that you're asking for a question of a copy of the webinar. We will send you a video automatically, and that should show up tomorrow. Dr. Faruqi, you're very welcome. Thank you for coming. All right, thanks again and have a great day, everybody. Take care.